to today's edition of Pathcast. Today is November 26th, 2024, and it's a Tuesday. We are almost towards the end of the year. And so today we would have a cytopathology lecture, and our today's guest speaker is Dr. Ashish Chandra, and we are happy to welcome him back. So he previously gave a talk on another topic recently. Thank you, Dr. Chandra, for coming back today. And just an introduction, Dr. Ashish Chandra is a very renowned cytopathologist, and currently he works at Guy's and St. Thomas's at NHS Foundation Trust in London, UK, and he works there as the lead consultant for cytopathology and uropathology, and he holds many honors, including he was the past chairman for British Association of Urological Pathologists, and he also served as vice president of International Academy of Cytology, and most recently, he got the International Achievement Award for American Society of Cytopathology 2024, and congratulations, Dr. Chandra, for that. And for our viewers, you can reach out to Dr. Chandra on his Twitter X account that you can see on the screen. So he is quite active, and if you have any questions, you can reach out to him. And for today, for our viewers, if you have any questions or comments, please post them on Facebook and YouTube chat windows. And in fact, Dr. Chandra is going to have an interactive case-based discussion later. And you please stay alert and then post your answers on the chat windows on YouTube and Facebook, and I will pass them on to Dr. Chandra. And thank you again, Dr. Chandra, for coming over today. Over to you now.
Thank you very much, Dr. Manan, for inviting me back. And it's a real joy and a pleasure to be online this afternoon in London. It's 5 o'clock in the evening, but I realize that I have friends who are joining in from the East, so wish them a very good evening and a very good day to those of you who are joining from the West. So this is a view from my window today. The Christmas lights are, coming up, and, London is becoming, feeling very festive with all the shopping and all the lights coming up. So it's a great time to be here. But of course, what we will talk about today is another great city, the city of Paris, for which, which has been made even more famous besides the Eiffel Tower, by the Paris System for Reporting Urinary Tract Cytopathology, by Dr. Eva Wojcik, Dr. Curtis, and Dr. Rosenthal. And I'm sure you're familiar with this. It's impossible to do a talk on urinary tract cytology without mentioning the Paris System. So here goes. I am just going to turn off my video. And then I will switch it back on again at the end of the presentation. So the plan this afternoon is to do this presentation, which will be about sort of 15 to 20 minutes. And then after that, I will show you some cases, and we'll keep it nice and lively and interactive. So you can put your answers in the chat box, and you're welcome to ask me questions as we go along. And I will take some of them at the end, but also when we get to the cases, I'm happy to take the questions pertaining to each case. So urinary tract cytology is something that cytopathologists are justly quite proud of, because over the decades, this is one area of cytology in which our performance is really very good in recognizing high-grade urothelial carcinoma, and that is the strength and stay of urine cytology, to be able to recognize high-grade urothelial carcinoma. The low grades are really not relevant to cytology. Cytology is not the right test for picking up low-grade urothelial neoplasia. Those are the realm of cystoscopy and biopsy histology. So that's partly the reason why historically urine cytology may have received some bad press, showing that its sensitivity is only 50 to 60% in the low-grade territory of urothelial carcinoma, but that is not the purpose of doing urinary tract cytology. The purpose is to detect high-grade urothelial carcinoma. And that is something that we are very good at. We should also recognize that the molecular pathways for the transformation of normal urothelium to sometimes precursor stages of dysplasia or hyperplasia, going on to urothelial carcinoma, is accompanied by some very specific molecular changes. And as these are being described in non-invasive and muscle-invasive disease, the role for urinary cytology will grow because some of these biomarkers can in fact be picked up on testing the urine. And so these would form an important adjunct to urine cytology. And they also have the added advantage of being able to pick up even low-grade urothelial neoplasia, which as I said, cytology is not great at. So cytology, wonderful for picking up high-grade urothelial carcinoma, and low-grade as a combination of perhaps coming urinary biomarkers, but also cystoscopy and biopsy histology. So I'm pretty sure all of you are familiar with the Paris system, the first edition, which came out in 2016. But in fact, the story has moved on because we have now moved on to the second edition of the Paris system. And if you haven't been using it, now would be a great time to start, because all of the literature that has been published since the first edition was published shows that the performance of urinary cytology has improved in terms of sensitivity, specificity, positive predictive value, as well as negative predictive value. And so it has improved screening and surveillance potential of urine cytology. It has reduced the rates of the atypia category. And so it's improved the sensitivity of the test and providing a proper risk stratification for patients. So what's new in the second edition, which has now been out for almost 2 years? And again, I'm sure many of you are already aware of this, but the key changes have to do with the addition of new images, up-to-date references, more sample reports. There are also new chapters on upper urinary tract cytology and the risk of high-grade malignancy, which is a better indicator of clinical outcome compared to simply risk of malignancy, which includes both low grade and high grade. So if anything, it really further reiterates the importance of high risk urothelial carcinoma. So this is the main change really in the diagnostic categories. Low grade, which used to be category 5, has been shifted up and subsumed within negative or high grade urothelial carcinoma. And so, 5 now becomes high-grade urothelial carcinoma, and 6 will be the other primary and metastatic malignancies. So if you're reporting low-grade urothelial neoplasia, you basically have to report the specimen as negative or high-grade. And then you can say that because of the presence of certain features, which I will come to shortly, you suspect that there may be low-grade urothelial neoplasia present. But this is a very uncommon clinical scenario. So the fact that low-grade urothelial neoplasia is included under the negative category goes to just strengthen the message that the focus of urinary tract cytology is on high-grade disease. And LGUN remains a mainly cystoscopic finding visible to the urologist, who will then biopsy it or resect this lesion. And only occasionally will this be suspected on cytology because of the bland cytological appearance of the urothelial cells and the finding of fibrovascular cause. This can be seen better if you use a cell block. If you suspect that there may be some fibrovascular cause seen on your cytospins or liquid-based preparation, you could submit the rest of the residual sample for a cell block, and then it becomes almost as good as a biopsy because you will appreciate the architecture much more and the cytology will still be bland, and you may be able to propose a diagnosis of low-grade urothelial neoplasia, but you would still report it as negative for high-grade. And this will just require confirmation on cystoscopy and biopsy. Now, one of the great things that the Paris system did was to lay down some criteria for adequacy of urine cytology specimens. This is something that had not existed previously. So this is one of the great successes of this terminology system. So you have to bear in mind that adequacy of urine specimens is an interplay of four different factors. You have to know what the collection type is, and we don't often get told whether it's a voided sample or it's an instrumented sample of some sort, but it is very important when it comes to interpretation. And if this is not stated uh, in the request form, then you should perhaps end your report with a question, you know, is this an instrumented sample? Or, how was the sample collected? Because the interpretation of the cytology will rest on knowing this factor. Of course, there is cellularity and there is volume, but ultimately it is down to cytomorphological findings. So in terms of cellularity and volume, what is recommended is 30 ml of a urine sample, particularly if you're using liquid-based cytology preparations like FRCPath, 25 ml if you're using ThinPrep. And in terms of the cellularity, because urothelial cells are present in such variable numbers in voided urine, there is no recommended number suggested for voided samples. Most of the work that has been done in literature is centered around bladder washing specimens, where it's been recommended that you should see 20 urothelial cells per 10 high power fields in a ThinPrep sample. And if there are only between 10 to 20 urothelial cells, the sample could be regarded as suboptimal, and less than 10 urothelial cells per 10 high power fields in bladder washings should be regarded as non-diagnostic. In terms of volume, it's important to remember that the confidence in picking up malignancy, high-grade urothelial carcinoma, is optimal around 25 to 30 ml of a fresh, voided, mid-morning sample. Of course, that's not to say that we should reject samples that are smaller than that. I think we should receive them and still process them, nor should we discard specimens that are larger in volume. So this is the optimal volume where the chances of finding high-grade urothelial carcinoma are optimized. This is your sort of summary table, and we will apply it when we do our interactive cases in a few minutes' time. So this is a sort of a summary table of the Paris system. And the starting point for this is the nucleocytoplasmic ratio. And is the nucleus filling up more than half the cell? You should not interpret or attempt to interpret degenerate cells, and you should also not interpret intermediate and basal urothelial cells. So you need to go for the urothelial cells which are well preserved and not use the umbrella cells or the basal cells. If the NC ratio is not raised, then of course the sample is negative for urothelial carcinoma. If the NC ratio is high, then depending on the NC ratio, look for hyperchromasia, coarse chromatin, and irregular nuclear membranes. So if two of these features are present, then you become suspicious that there probably is high-grade urothelial carcinoma. And if you have only a small number of cells, say between 5 and 10, but with a high NC ratio of more than 70%, then you should probably just stop short at calling the sample suspicious and maybe recommend cystoscopy and biopsy. But if there are more than 10 cells that you can recognize confidently, which have a high NC ratio of greater than 0.7, and they have at least two of these features of hyperchromasia, coarse chromatin, and irregular nuclear membranes, then you can make a confident diagnosis of high-grade urothelial carcinoma. If only one of the features is present, then you would report that as atypia, and we'll talk about what you can do with these samples. If there is a reason for the atypia, such as polyomavirus or granulomas, or the sample collection method is, an ileal conduit, or there is a history of urinary stones, or there are obvious reactive changes, you should not use the atypical category. You should describe these changes and say that they may be associated with these conditions and report the case as negative. So this is a bit of an eye chart test, isn't it, at the opticians? The important thing is that cytologists are very good at recognizing NC ratios which are high. So the ones that are greater than 0.5 and closer you get to 0.8, the greater the degree of concordance among cytologists for calculating or assessing the nucleocytoplasmic ratio. But at the lower end of the spectrum, the 0.3 or between even 0.5 and 0.7, there is a significant inter-observer variation. So don't be disheartened. You can keep this, eye chart next to your microscope amongst all the other things that are pinned to your wall, in order to assess the NC ratio of urothelial cells. So before we go on to look at some cases, let's see some classic images of the different diagnostic categories. So negative for high-grade urothelial carcinoma, where you just expect to see some normal urothelial cells, which are not degenerate, they are well preserved, they're not the umbrella cells, they're not basal cells, there is no deep hyperchromasia in these cells, and the NC ratio is less than 0.5. So all the cells that you're seeing in these pictures, even if they're present as groups, can be regarded as benign. With reactive urothelial cells, what you can get are some nuclear changes in the form of a little bit of nuclear enlargement, but it's a uniform nuclear enlargement from one cell and one nucleus to the next. The chromatin is finely dispersed. The shape of the nuclei is still round to oval with smooth nuclear borders, and they contain multiple small nucleoli. And these are the features that you expect to see with reactive or inflammatory changes. If you're wondering about high-grade urothelial carcinoma in such a case, just ask yourself, where is the deep hyperchromasia? Where is the coarse chromatin? Where are the irregular nuclear membrane folds? So the fact that you've got finely dispersed chromatin with multiple small nucleoli and smooth round to oval nuclei should take you away from calling this specimen atypical or suspicious. You should report these as reactive or inflammatory changes, and the bottom line in the category will be negative for high grade. I will cover low-grade urothelial neoplasia here, which are characterized by this very rare occurrence of fibrovascular cause. You see, this looks like a mini biopsy when you see these papillary clusters, and you can see this sort of pale fibrovascular center to this papilla. If you get fragments of these in a urinary tract sample, then you could say that these changes may be associated or are associated with low-grade urothelial neoplasia. You could make a cell block to bring out the architecture even more, and you could suggest that cystoscopy and biopsy is advised, and in order to exclude a low-grade urothelial neoplasm, and you would sign the case out as negative for high grade. So, like I said, we don't really want you to use the word atypia for reactive changes. I would suggest that you substitute the word atypia there for changes, inflammatory changes, reactive changes, degenerative changes, or regenerative changes. All of these are physiological phenomena, and they should not be reported as atypia. So, also when you know the cause or why you are seeing any abnormal features in the nuclei, polyomavirus treatment, or special types of urine samples or contaminants. Don't use the word atypia. You can still sign them out as negative, but just call them reactive changes. So when should you use the term atypia? So these again should be used in the non-superficial umbrella cells and non-degenerated urothelial cells with a high NC ratio of greater than 0.5. And together with that high NC ratio, there should be hyperchromasia compared to the umbrella cells or intermediate squamous cell nuclei that you might see in that preparation. And also irregular clumped chromatin and irregular nuclear membranes. Only one of these is required for atypia. So you see, atypia is no longer a diagnosis of exclusion. It is very much a diagnostic category which has strict diagnostic criteria. And without these being present, you should not use it. And you might just want to call it negative and report them as inflammatory or reactive changes. So in atypia, you see the NC ratio is still relatively low, but you've got hyperchromasia. You might have irregular nuclear borders. And so, if you see a whole group of these, you may even be tempted to, call this suspicious. So, there can be a little bit of inter-observer variation in this group, but you do want to apply the criteria uh, as well as you can to be able to prospectively make a diagnosis of atypical urothelial cytology, because what you can do for these cases is send the residual sample for something like Eurovision fish testing. So with atypical urine cytology, we tend to send off an unstained thin prep slide for doing a fish stain in our cytogenetics laboratory. And they use a cocktail which contains 4 probes. And if any of these probes is positive on immunofluorescent microscopy, the cytologist who's looking at the test will report it as positive. And those patients will then go on to have a cystoscopy and biopsy of any abnormal lesions. And in our experience, all of these patients on follow-up will develop a neoplasm in up to 2 years. So they may have a couple of cystoscopies every 6 months, and then they might pop up a papillary tumor or CIS. The ones who test negative tend not to have any tumors, and their cytology returns to negative, and they can be returned to routine follow-up. So that's what you do with the atypical category. If you don't have access to Eurovision fish, you could also in the future perhaps use urinary biomarkers. But at the moment, if you don't have access to them, you should probably just either ask for a repeat sample or refer the patient for cystoscopy and biopsy. The suspicious category requires an NC ratio of greater than 0.7 and hyperchromasia. So both of these are required criteria. And then one of the following: irregular clumped chromatin or irregular nuclear membranes. So, in your mind, when you are looking at urine cytology, this is the mantra that you are reciting in your mind, high NC ratio, deep hyperchromasia, coarse chromatin clumping, irregular nuclear membranes. And, you may not see all of these features in the same cell. You might see them in somewhere in the sample, but as long as you can find all of those features in that sample, and depending on how many cells you can find. So if you can only find 4 abnormal cells like these, then you should probably just call that sample suspicious for high grade. Whereas if you found 10 or 12 of them, you could perhaps be a little bit more confident. So with smaller numbers of these abnormal cells, perhaps you should be a little bit more cautious, call it suspicious, and refer the patient for cystoscopy and biopsy. But if you're able to find 10 cells meeting those Paris criteria, then by all means call it high-grade urothelial carcinoma. So this is the typical sort of appearance where you have a high diagnostic yield, lots of abnormal cells displaying the features of high-grade urothelial carcinoma, high NC ratio, hyperchromasia, coarse chromatin clumping, and irregular nuclear membranes. So that is what you're sort of chanting in your mind as you move from cell to cell in a urine cytology sample. And provided you can find a good number of them. Now, 10 is a very arbitrary number. I might be happy sometimes with just 8 abnormal cells, particularly when I know that the cystoscopic findings were clearly abnormal. And so there, I won't say, well, there are only 8 abnormal cells, so I'm not going to call it high grade. So it does, the clinical context and your experience can influence this. So this is not a very strict cutoff. You can, occasionally pick up other malignancies in the urine, adenocarcinomas, clear cell adenocarcinomas, lymphomas, melanomas, but I'm just mentioning these, uh, for completion's sake. These would be suspected either if there is an existing story, clinical history, or you might just suspect it because of the morphology and then investigate the patient further, or make a cell block and do some immunostains and prove your diagnosis. Correlation with histology, of course, is the best way of learning cytology, and you will find that even histology is not perfect in terms of urothelial disease. I'm a urothelial histopathologist, and I, rely both on cytology and histology, particularly for grading, and also correlation of the upper tract biopsies, because you can get a mismatch where, in fact, cytology is often right, and histopathology suffers from inter-observer variation and sampling errors just as much as cytology does. So my advice is to report these samples together whenever possible, particularly from the upper tract. So last couple of slides now. These are the diagnostic criteria of the Paris system and the risk of malignancy of high-grade carcinoma as stipulated by the second edition of the Paris system. And I would encourage you to read the book and to familiarize yourself. And this shows you the relative risks of malignancy with the different categories. So my last slide, and then we move on to some cases. I can take some questions at this point as well. Is that the Paris system is a continuing success story. It has a high clinical impact globally because these are especially, very common cytology specimens in the lab. The important thing is that the Paris system can be applied to these samples, whether they're from the lower tract or the upper tract. It has provided useful advice to clinicians and patients on how much sample needs to be collected. And the system can be applied both to cytospins as well as to liquid-based preparations, such as SurePath and ThinPrep. It has reduced the atypia category so that it's improved its performance. We now know what sort of risk of malignancy associated with this atypical category, and it correlates with histology and the new and developing ancillary tests such as Eurovision FISH and some of the biomarkers. One very important thing to me as a histopathologist is that this is the first time that anyone has acknowledged the fact that the non-invasive tumors in the urinary tract should be referred to as neoplasia rather than carcinoma. So this is an anomalous situation in urothelial tumors that you call them urothelial carcinoma even when they're non-invasive. There is no other site in the body where you would call something a cancer or a carcinoma if you cannot demonstrate invasion of the subepithelial tissue microscopically. And so this remains an exception and an anomaly. But cytology is ahead of the game here with histopathology because the Paris system recommends using the word neoplasm rather than carcinoma. And I would say, I'd certainly recommended to the FRCPath, the Royal College of Pathologists, to include the new terminology systems like, Paris, Milan, and also the International System for Reporting Serous Fluid Cytology in the training curriculum. And the trainees actually are much happier because they like a uniform approach to report writing so that, they don't have to rely on the variation that commonly exists between different teachers. So thank you very much for listening to the talk. I will stop sharing the screen. If there are any quick questions, I would be happy to take them. Rifat, I don't know if you see any questions in the chat box. If not.
One question, Dr. Chandra, that I see in the chat box, it's about what are the limitations of the Paris system for reporting?
Okay, so in terms of the limitations of the system overall, I would say that there is an overlap in the risk of high-grade malignancy, as you saw in the table that I showed you a minute ago. But that is data that has been collected internationally. What I would recommend is developing your own, or through audit of your own data to determine the risk of malignancy of the different diagnostic categories in your department, in your own institution. And then that way, the risk of malignancy that you will be aspiring to will be much more relevant to the patient group that you serve. So in the Paris system, we saw that there was a range of high risk urothelial carcinoma for each diagnostic category. And it looks like there is a very big overlap between some of the adjacent categories. So it may come across as a limitation of the system that there is such a wide overlapping range. But my advice, my remedy for that is to develop your own risk of high-grade malignancy for not just for urine cytology, but across all cytology specimen types for thyroid, salivary glands, serous fluids, because it just depends so much on your case mix and your workload that you might be seeing more malignant cases in your institution if you work in a cancer center like I do. But if you work in a community hospital, you're likely to see many more of negatives or atypical samples. So that I would perhaps regard as one of the limitations, but there is a remedy for it. Thank you for your question.
Right. Thank you. So there's another one, Dr. Chandra. What is your experience on cell blocks in urine cytology? One of our viewers asked that.
Yeah, great question. I've already sort of mentioned it in the course of my talk to say when I suspect low-grade urothelial neoplasia because I've just seen one group which seems to have a possible, hint of a papillary architecture, and I want to look harder for more groups rather than asking for more cytospins or thin prep. I then ask the lab to prepare a cell block instead because that then gives you the microarchitecture. In particular, the fibrovascular cores become much more readily apparent. And this is true for the very cellular samples, particularly instrumented samples from the upper tract, where again the diagnosis of low-grade urothelial neoplasia can be important because the patient would undergo a nephrouretrectomy even if you diagnose low-grade urothelial neoplasia in the upper tract. So if you see fibrovascular cores in a sample from, say, renal pelvic washings, then rather than asking for more cytospins, I would suggest that you request a cell block in a very cellular specimen. And of course, if there's any accompanying biopsy, always correlate with that. Also, doing a cell block can be quite useful in the rare instances where you have perhaps features of polyoma virus in the specimen, and so you can do your SV40 immunostain in those cases, or of course, when you're making the diagnosis of unusual or rare presentations of other malignancies in the urine, such as adenocarcinomas or melanoma or lymphoma, there again, you can use the residual sample for making a cell block and do your ancillary workup on those. Thank you.
Right. No, I have a question for you, Dr. Chandra.
Sure.
There are quite a few more questions in the chat box. Do you want to take them at the end of the lecture or you want to take them now? Because you want to share some cases as well, right?
I do, but I don't mind taking maybe a couple more questions and then I'll go on to the cases. And I'm sure those questions will get answered either in the course of the discussion or at the end as well. I don't mind. Maybe we can do a couple more.
Yeah, so there is one more. I think maybe you answered that already, that any recommendations to increase cell yield?
Right. So yeah, one would be requesting a cell block. The other would be to, of course, ensure that you are getting the right volumes of the samples from your urology team. You may need to remind them that if they're continuing to send you just 5 or 10 mil sample, what you can do is you can report them as negative or high grade, but in your report put, that the recommended volume for avoided samples is 25 to 30 mil, so that even if they're getting a negative report, it is actually a suboptimal sample. But if you keep putting that in your reports, we do that even for our serous fluid samples, keep reminding the physicians that you need to send 75 mil of a serous fluid sample. And if you keep putting it in your reports for samples that are of smaller volume, the message is repeated and it eventually gets through, and you'll see that the samples that you get meet the volume criteria for adequacy if you keep repeating that message. So that's how I would try and improve the yield, by reminding the clinicians to send optimal volume samples, but also you can use cell blocks. Thank you.
Thank you. So there is another question about utilization of immunos on urine cytology. How often do you do it, or do you do it on cell block or smears?
Yeah, so again, I think I partly answered that question. It's rare that we need immunostains on urine cytology. I think the future will be doing urinary biomarkers, looking for gene panels that look for mutations that are associated with low-grade and high-grade urothelial malignancy, like FGFR3 mutations and telomerase and TP53 and KRAS. So going forward, I think we will see biomarkers that will be increasingly used rather than immunostains. Immunostains might be useful for confirming polyomavirus, infection, reactivation, or for rare presentations of melanomas, lymphomas, or adenocarcinomas. But very rarely do you need to do that for urothelial malignancy. Thank you.
Right. So the next question is about high-grade urothelial carcinoma. So is it that high-grade urothelial carcinoma can be diagnosed under the Paris system with hyperchromasia and nuclear membrane irregularities if the NC ratio is below 0.7? And how often this is applied in practice?
Yeah, so the Paris criteria really do say that the NC ratio should be high. If you have got hyperchromasia and of course chromatin clumping, perhaps it is better to apply the suspicious category to those cases. You still wouldn't be wrong, because the positive predictive value of even the suspicious category is actually very high, and urologists take the suspicious category very seriously. So they will go on to do a cystoscopy and biopsy, or if necessary, even upper tract imaging and ureteroscopy, if you report those cases even just suspicious, simply because the Paris criteria are not being met. I would suggest apply the criteria as they are laid down, because that's how they're validated. If your particular sample does not meet the criteria for a high grade, then report it as suspicious.
Right, thank you. There is one question about, is there any exceptional cases for minimum cell numbers?
Exceptional cases would be, where you have perhaps, a very compelling clinical or cystoscopic findings of a bladder mass in the patient, but the sample is, quite degenerate, and the number of well-preserved cells in which you can diagnose malignancy is, relatively small. In those cases, again, I would suggest just using the suspicious category, and it will be treated as if it's a positive, because urologists, as I say, will go on to do further investigations in those cases, particularly if there is a bladder mass and you're only calling it suspicious. But you don't need to move the goalposts to fit in with the diagnosis. That is a recipe for making a mistake. That, well, the urologist thought there is a tumor there, and so I called it high grade, and now they can't find anything. And then you're a bit stuck because you didn't apply, your own cytological criteria. So I would suggest that you apply your criteria independently of radiological and clinical findings. And that is a piece of advice I offer for thyroid nodules or salivary gland FNAs as well. Just because the ultrasound findings are that of a malignant nodule, in the thyroid or in the salivary gland, doesn't mean that you've got to upgrade your diagnostic category from a suspicious to malignant. There is a reason why we have tumor boards and multidisciplinary meetings to explain the mismatches and lack of correlation, perfect correlation sometimes between imaging and cytology or clinical findings. And that is a good thing. It is safe clinical practice to disagree if you don't have the cytological or histological criteria met down the microscope.
Thank you, Dr. Chandra. I think you can go ahead with your cases, and some questions we can take later on. Thank you.
Excellent. Thank you. So my first case is a male of 58 years, hematuria, smoker, and one thin prep. And so this is going to be a little bit like a multi-header session, a digital multi-header session online. It's going to be a bit of a rapid on-site evaluation for all of you, I'm afraid, as you will only get a few seconds to assess these cases. But it doesn't matter. We are here to learn. And if it's a little bit challenging to make conclusive diagnosis, don't worry about it too much. So this is a man with hematuria and a smoker, and this is voided urine cytology and a thin preparation, which we are scrolling down. And you're no doubt seeing a lot of normal urothelial cells. So this is at the highest magnification possible. And you'll see most of them have, normal NC ratio, normal chromatin. And so, you've got a population here of normal urothelial cells. And within the same sample, you have a contrasting population with higher NC ratio and hyperchromasia. And you're seeing some cells that you would probably call no more than atypical, some that you might call suspicious. And once you see sufficient numbers of suspicious cells, you might even go all out to call it, frankly, malignant. So I'm showing you the first case as an example just to get your eye in, to set the threshold for what we will call high-grade urothelial carcinoma, but also to show you that you can teach yourself the Paris system by looking at some good examples of high-grade urothelial carcinoma, because within those same cases, those same samples, you will be able to see cells in the background that only meet the criteria for atypia or suspicious in terms of, so you've got to ask yourself every time you look at a group of cells, what is the NC ratio? Is there deep hyperchromasia? Is there coarse chromatin clumping? Are there irregular nuclear membranes? And across the sample, you're looking for 10 cells, which collectively, not every cell will necessarily fulfill the criteria, but if across the sample, you can find 10 cells that will meet the Paris criteria, all 4 of those features, then you could report that as high-grade urothelial carcinoma. So I'm showing you this first case as a positive case for high-grade urothelial carcinoma, but also to give you the clue that, I've really taught myself the Paris system by learning to recognize atypical cells and suspicious cells in the clearly malignant cases, and then learning, if I only had those cells in the sample that I had, I would probably go no further than atypia. Or if I just had just these 4 or 5 cells in the entire sample and no more, I would probably just report those as suspicious. So it gives you a chance to teach yourself both the qualitative criteria of the Paris system and also to then be able to find how many malignant cells you can find across the entire sample. So whether you call this case suspicious or frankly high grade is good enough. You haven't had much time to see this case. So I would say as long as you agree now that there are 2 populations here of completely normal urothelial cell, and then a second population of malignant urothelial cells. Okay, any questions arising from this case? I'll wait for a few seconds before any questions come in.
I don't see any questions, Dr. Chandra, now.
Okay, cool. Excellent. Let's go on to our next case then, which is that from a 52-year-old female with suspected upper tract transitional cell carcinoma. And again, I will show you one thin prep. And this is at the lowest magnification. And even at this low power, you can see that there are some papilloid clusters, really dark staining, deeply hyperchromatic. And again, in a case like this, there should be no doubt once you look at the dispersed cells first. So my message with this case is don't home in into the larger cohesive papillary clusters because you won't be able to make out the NC ratios there. Go for the cells in the background, the singly dispersed ones, or in the ones in the small groups. And, by contrast here, you've got a completely normal urothelial cell, or maybe here. And then, compare this with this these cells, which are deeply hyperchromatic, high NC ratio, singly dispersed, as well as in small groups and clusters. And it doesn't matter whether this sample is from the lower tract or upper tract, or whether this is a thin prep, or this is a SurePath or a cytospin. The criteria for the Paris system are the same. And so I would put it to you that this is an example of high-grade urothelial carcinoma. But even if you'd stopped at suspicious, it's okay. Don't worry. You've only had, a few seconds to make your mind up on these cases. And the other message was, when if you only have clusters like these and you don't have the dispersed cells, look at the edges of the clusters because you may not be able to see in the middle, but the cells at the edges of these papilloid clusters will show you that they have deep hyperchromasia and high NC ratio. But my word of caution is rather than just zooming in into the big groups, start with the dispersed cell population first to pick up the features of high-grade urothelial carcinoma. So I hope, in spite of the fact that this is from the upper tract, you will have no difficulty in recognizing that there are clearly malignant cells present here that fulfill the Paris criteria, and they're present in sufficient numbers to be able to make a confident diagnosis. Again, in the background, you will be able to find some cells that you're only able to call atypical or suspicious. But this is why you need to evaluate the entire specimen. And if you only had the atypical cells, you would report it as atypia. If you just had 4 or 5 cells that were suspicious, then you would report that as suspicious. But having so many malignant cells, you should have the confidence to be able to call it frankly malignant. Any questions or comments in the chat box?
Not that I see, Dr. Chandra.
Okay, good. The first 2 cases are kind of just warm-up cases to get our eye in, because it is difficult to be able to just make diagnoses and sort of share them online at such short notice. So don't worry. Okay, case number 3 is female of 68, hematuria, ex-smoker. And again, thin prep. At low magnification, there are some darker, larger clusters. And as we increase the magnification, so you want to see where the clusters are because you have to go back to them. But, they all look really dark and quite scary. So don't get influenced by these too quickly. First, examine the background cells. The dispersed cells in the background. not as cellular as the last one. Let me reduce the magnification a bit while we're screening. So that for setting the bar is perhaps a normal urothelial cell with normal chromatin pattern. And let's just keep looking. I don't think you've seen many cells yet to be able to offer me a diagnosis, but that is partly the point of this case. You see them now. Some cells with high NC ratio, but very few in number, right? So just two here, and the sample overall is not very cellular. So, perhaps safe only to go as far as suspicious in this case, which is what we did. There is blood and crystalline debris here in the background, but the number of abnormal cells was not sufficient to make a confident diagnosis of high grade. So based just on the presence of those few cells, we called it suspicious. But you can see the groups here, which are the more papilloid groups. They also have darker nuclei, but they are much harder to assess. It's the dispersed cell population here that will get you to the safest diagnosis in such a setting with all the degenerative changes that are present in this sample to perhaps go no further than suspicious for high grade. So suspicious is more of a quantitative entity. It depends on the number of cells, abnormal cells that you are seeing that are abnormal. And if they are very few, then you stick with the suspicious category. And if they are more than 10 or 12 in the urine, then you can be a little bit more confident. So these are all just degenerate changes of cytoplasm and the nucleus, but the chromatin is quite dispersed. There are multiple nucleoli. So those are not your suspicious cells. Your suspicious cells are the ones with the dark chromatin and high NC ratio. So in this case, perhaps acceptable to only go as far as suspicious. Okay. Any questions or comments arising from this case?
They agree that it is suspicious.
Good, very good. So yeah, if you just have, suspicious and malignant, the difference is quantity. And if you just have more, then you can make a definitive diagnosis. And again, that principle in general applies across the board to not just cytology, but for pathology. If you've got enough in terms of quantity, then you can call it malignant. But if you wish you had more or need the support of ancillary stains, then you should probably stick with the suspicious category. Whereas in the atypia, there are qualitative differences. Not enough diagnostic features are present in the sample for you to even use the suspicious category. So it is a step back because the cells do not show sufficient diagnostic criteria to call them high grade. Okay, case number 4, then is a male of 43 with hematuria, and this is a cytospin. Always stained with PAP, of course. We don't recommend using the Giemsa stain. Okay. So notice about this specimen that there is no contaminant squamous cells, but what you do have here is some contamination by spermatozoa in the background there. And then the cells that you're seeing here look very bland, but some of them are a little, or some are a little bit more columnar shaped. Here for comparison is a normal urothelial cell. There are some, bare nuclei in the background. And again, slightly more stretched columnar to spindle-shaped cells, but the nuclei are following the shape of the cell and the cytoplasm, and there's no high NC ratio, no deep hyperchromasia, coarse chromatin clumping, or irregular nuclear membranes. So what do you think is going on here? What has the description that I've given you most likely to represent in this case? Any comments or answers in the chat box yet? Okay.
So one
I'll
comment,
take.
one comment, Dr. Chandra, or question is, do we count only the discrete cells?
No, take into account by discrete cells. Do you mean well-preserved cells? Yes, you should only, evaluate or assess the well-preserved cells, not the degenerate cells. Cells in which you can actually study the cytoplasm and the nucleus, because the NC ratio is such an important part of making a diagnosis of high-grade urothelial carcinoma. But the overall pattern, does this not strike you as something unusual? Does this strike you as, this doesn't look like a voided urine sample? Why is it so cellular? And what are these, all of these cells in groups and in sheets and with these elongated cells? So this is a bladder washing specimen. It is negative for high-grade urothelial carcinoma because nothing was actually visualized at cystoscopy. So there was nothing to biopsy, but because the patient had hematuria, and the voided urine cytology was negative, the patient underwent a bladder wash. And in the bladder wash, you would recognize it by its high cellularity. We saw this at low power. It looked very, very cellular. And
one
it lacks
comment
any.
here, Dr. Chandra, sorry to interrupt.
No.
Is there any history of conduit or any vesico, colovesical fistula?
No, there isn't. But ileal conduit samples look very different. There, you get a lot of degenerative changes of the cells, and they usually just singly disperse, and you get lots of bacterial contamination because it's basically urine that is being excreted from the kidney directly through the ureter into the intestine. So you get a lot of bacterial overgrowth and a lot of degenerative changes. So this is not the appearance of an ileal conduit sample, but this is the appearance of a bladder washing sample where you get sheets and groups of these urothelial cells. Because the bladder is a distensible organ, the urothelium also needs to be a distensible epithelium. It has to respond to the contraction and relaxation of the bladder. So normal urothelial cells can stretch, from round or polygonal cells to columnar or even spindle-shaped cells. But the important thing is that the nucleus also follows the shape of the cell and of the cytoplasm. So you're not getting any bulging of the nuclei beyond the cytoplasmic borders or boundaries. These are all just sheets of urothelial cells. The situation is analogous to, I would say, a peritoneal washing specimen, where you get strips of mesothelium that look like this. You see, that could do for a sheet of mesothelial cells if I told you this was a peritoneal washing specimen. The idea is the same. You're putting in a jet of saline into the bladder, and then you are reaspirating the saline through the catheter, and then you're spinning it down. So you're getting lots and lots of sheets and dispersed urothelial cells, maybe some contamination by spermatozoa in a man, but you're not seeing any contamination by the urethral, lower genital tract squamous cells. So a clean sample, very cellular, with cells in groups, in sheets, and showing a little bit of variable morphology, but no high NC ratio. So what you're doing here is effectively you're looking in between these very normal looking sheets of urothelial cells, and you're looking for any evidence of carcinoma in situ cells, occult CIS, that may have been missed at cystoscopy. So it's a belts and braces approach when the patient has hematuria, but the cytology was negative, the cystoscopy is negative, there is nothing to biopsy, and so before they take the catheter out, they also wash the bladder and send it to exclude any evidence of occult CIS that may have been invisible to the cystoscopist. So again, you're screening in between these benign urothelial cells with this variable columnar, spindle, or polygonal cell morphology, and applying the Paris criteria for deep hypochromasia, high NC ratio, coarse chromatin clumping, and irregular nuclear membranes. And your conclusion is that this is a negative bladder wash specimen. Any comments or questions?
Not that I see here.
Okay. Let's go on to our next case then. A female of 58 with hematuria. I've got to make sure this is the right case. Oops. Just things are just one, two, three, four. And this is the fifth case. Okay, let's see what we find. Okay, I know which case this is. Right, okay. So here's a granular cast, very sharp cylindrical edges. Not much by way of any acute inflammatory exudate in the background. See lots of contaminant, bland, normal squamous epithelial cells, and then also some normal urothelial cells. Just going back to slightly lower magnification for a minute, so we can screen the sample to find the cells of interest, which are these smaller cells. Some of these might just be clumps of neutrophils, but then there are a population of smaller cells like these. Okay. Lots of contamination here by squamous cells, but again, some of these smaller cells with slightly high NC ratio, but not really fulfilling the Paris criteria for high grade. So what could those cells be? Any thoughts, comments, or questions in the chat box yet?
Let me check.
It's a difficult one. I don't mind if people haven't had enough time to make their minds up. That's understandable. There's a discussion around these cases that's important because
there is one question I see that was it signed out as benign? Did it have a biopsy? These spindle cells look misplaced. That is one question, one comment.
Okay, right. So as I said, there was nothing to see in the bladder at cystoscopy, so there was no biopsy. And I showed you that case as an example of what cellular but negative cystoscopic washings can look like. You can get that sort of artifact of the variable shapes of those urothelial cells. But there was no biopsy in this case, but the patient, of course, remains on a follow-up. So I understand your comment because it's an unusual finding, but that's the reason why I'm showing you these cases today. So for this particular case, these are um, glandular metaplastic cells secondary to uh, calculi. So although you haven't got much by way of inflammation, but there was history of calculus disease in this patient, and there was irritation to the bladder. And on biopsy, we just found cystitis cystica, and we also had some nephrogenic metaplasia. So sometimes you can just get glandular cells which look bland. You have to consider all sorts of possibilities, particularly in a female patient. Could these be endometrial cells? Is there any reason to believe that there might be some sort of contamination by either menstrual blood or an endometrial pathology? But once you have a history of calculus disease, then it becomes a little bit easier. And also, if you see the morphology of those cells, it was unlike those of endometrial cells, and there was just too much cytoplasm for endometrial cells. So they have a sort of a glandular morphology. At first look, they might look like these could be endometrial cells, but these on biopsy were shown to be glandular metaplastic cells, and there was a history of bladder and renal calculi. So it's a tricky case, but I'm showing it to you because it was called atypical. And then the patient did undergo cystoscopy and biopsy, but these changes were attributable only to metaplastic changes. So it can be quite tricky. And that's why I'm sharing this case with you. Any other questions or comments on this case?
No.
Okay, we can keep moving. Let's see what we have here. Right. So here is our next case. And this is a young woman with hematuria. Quite a lot of bacilli there in the background, just contaminant, normal squamous cells, some degenerate urothelial cells, and then cells like these with a high NC ratio, small cells with granular cytoplasm, some with very hyperchromatic nuclei. What are your thoughts? So as time is moving on, I won't torture you too much with the answers, but this was suspected polyomavirus reactivation in a person in whom there was no history of any transplantation. This was just following an acute viral illness, flu-like symptoms, and what we have here are decoy cells. And some of these have very dark hyperchromatic nuclei, high NC ratio, but the cells are quite small in size. They have granular cytoplasm. And you also have a second population of cells with nuclei in which the chromatin is really marginated to the periphery. And so this is BK virus. And what we did was, in this case, just seeing if I've got the SV40 immunostain. So this is the SV40 immunostain on the cell block, which is positive in those nuclei. And you can see some of these nuclei are really quite dark with very condensed chromatin. Others have a more rarefied chromatin. stained with the SV40. So these are the cases where you have this dual population of nuclei which are associated with a BK virus reactivation. Now, remember that this reactivation is taking place in the kidney, not in the bladder. So the cells that we saw are actually renal tubular epithelial cells. That's why I mentioned the granular cytoplasm and the smaller size of these cells. They look too small to be urothelial cells, but they've got really hyperchromatic nuclei. And so, these were called decoy cells because these mimic malignant cells to perfection. And so the only way you suspect them is when you see the granular cytoplasm, the small size of the cells, and the fact that you might get a post-inclusion stage of the virus reactivation in the same sample, which gives you a clue that this kind of cobwebby or lacy pattern of chromatin could be associated with polyomavirus reactivation. But bear in mind that these cells are coming down from the kidney. These are renal tubular epithelial cells. These are not urothelial cells from the bladder. So this is a very useful diagnosis or test in the diagnosis of polyomavirus. I'm going to show you one other case if I have it here. Yeah, this is a really florid case from a renal transplant patient. Again, showing the extreme changes that you can get in polyomavirus. You've got the deeply hyperchromatic, marble-like structureless chromatin, and then you've got others which have an empty-looking nucleus here, which is the post-inclusion stage, and the chromatin is completely marginated to the periphery of that nucleus. And seeing these two cell populations, you can also see degenerative changes of orangophilic inclusion bodies in the cytoplasm of many of these cells. These are all coming from the kidney. These are not urothelial cells. So this is what florid BK virus reactivation can look like. And of course, these patients are monitored through their urine cytology, but also through their serology. Of course, if you work in a transplant center and you get these samples regularly, you will learn to suspect them, but the history is very important. If I've given you a misleading history here of a 90-year-old man with a bladder mass, I would completely understand if you call this high-grade urothelial carcinoma with sarcomatoid differentiation or, some really nasty type of malignancy. And that's why BK virus is said to be the perfect mimic of high-grade urothelial carcinoma. I hope you will refer to my recent review article in Acta Cytologica on pitfalls of urinary tract cytology. It was a special issue of pitfalls across different cytological specimens. But we've summarized the different diagnostic pitfalls in urine cytology, both avoided and instrumented samples. So this is really a very florid example of BK virus nephropathy. Any questions or comments, Rifat?
No, Dr. Chandra.
Okay. Is somebody still out there, or have they all gone back to work?
No, there are a lot of people on
Okay,
YouTube
that's
and
all right.
podcast.
That's okay. That's okay. I mean, it's probably quite late in the eastern countries, and the ones in the west are probably saying, when can I get back to my cut up and reporting? But thank you for hanging in there with me. Let's do one more case, and then we'll perhaps call it a day. It's been over an hour and 15 minutes now. So okay. So this is another pitfall that I want to show you, and here by the quantity of this spermatozoa that you see in the background. And these accompanying cells with hyperchromatic dark nuclei. But again, granular cytoplasm, these are seminal vesicle epithelial cells. So here you haven't got the same sort of chromatin changes that I showed you for the BK virus. This is just a non-diagnostic sample. So you shouldn't be reporting this as atypical or negative. You should just call this non-diagnostic because it's heavily contaminated by spermatozoa. and is accompanied by seminal vesicle epithelial cells, which are these cells with dark degenerate nuclei and granular cytoplasm. These can also be a pitfall in diagnosis in voided urine samples, but the heavy contamination by the spermatozoa will give you a clue that this isn't actually a good urine sample. So lots of degenerative changes, and I would recommend that you call this non-diagnostic and ask for a repeat urine cytology sample. Okay, so this is also a potential pitfall in an overcall for high-grade urothelial carcinoma, simply because seminal vesicle epithelial cells can also have larger and quite hyperchromatic nuclei. For those of you who look at prostate pathology and seminal vesicle histopathology in radical prostatectomy specimens, you know how frightening seminal vesicle epithelial cells can look, even on histology. So this is just a reflection of those cells contaminating a urine sample and causing a potential pitfall in mimicking high-grade urothelial carcinoma. I think I'll stop there if that's all right, Rafat.
No, actually, you may continue if you wish, Dr. Chandra. Our viewers have commented on YouTube that they are enjoying it and they are happy to be there and excellent cases and things like that. Please, if you have cases, please continue. No worry.
Oh, okay. Well, all right then. Let's do a couple quick ones. This is another voided urine sample. So at low power, you can see that there are some orangophilic squamous cells here, but rather than just contaminant squamous cells, these are really abnormal squamous cells with keratinization, large hyperchromatic nuclei. For comparison, right next to it is a nice normal umbrella cell with 2 nuclei and a very normal looking urothelial cell. So, just by comparison here, you can see here's a spindle cell, but very abnormal keratinized squamous cell. So this is squamous differentiation in urothelial carcinoma. You may not be able to distinguish between extensive squamous differentiation in urothelial carcinoma or a pure squamous cell carcinoma just based on urine cytology. And you would probably have to put in your report that there are scattered squamous cells present which are abnormal. They show high NC ratio and chromatin abnormalities consistent with squamous differentiation. This may either represent squamous differentiation in urothelial carcinoma or even a pure squamous cell carcinoma, and cystoscopy and biopsy is advised. If this was a female patient, you might also have to consider contiguous involvement of the bladder by, say, cervical cancer invading into the bladder, or simply just contamination by a squamous cell carcinoma of the vulva or of the vagina that is just contaminating urine cytology. So in female patients, you have to bear that possibility in mind as well, that this could represent a gynae squamous cell carcinoma, whether it's from the vulva, vagina, or cervix, or whether it is truly a primary bladder carcinoma with squamous differentiation. So if you find any evidence of urothelial carcinoma in these samples, that would be your best bet for saying, well, there is also evidence of high-grade urothelial carcinoma. You found some abnormal urothelial cells, and that could be supportive of saying that high-grade urothelial carcinoma with squamous differentiation is favored. However, cystoscopy and a resection of the tumor is recommended. Okay. Any quick questions or comments on this case?
1 second. So there is a question, Dr. Chandra. I'm not sure it's exactly related. If the history is not available to suggest immunosuppression, how to diagnose decoy cells in the previous case, especially when they are high in number?
Exactly. So that's a great a question. But this is typically why these cells are called decoy cells, because they can catch you out and find you, when you're not expecting to see these cells. So again, uh, there, look for the morphology, which I showed you in that case. You had the hyperchromatic nuclei, but then you also had this population of cells with completely empty nuclei, or ones with the lacy or cobwebby type of chromatin pattern. So that should alert you to the fact that this is BK virus in somebody who's not a transplant patient. And you can get normal, healthy people who may, from time to time, say during a transient flu-like illness, viral illness, uh, because of the transient immunosuppression, reactivate the virus in the body, which normally lives in the kidney, and then begin to excrete this in their urine. And if urine cytology is done at this time, perhaps to exclude, say, urinary tract infection in a young woman who's feeling unwell, may have some urinary symptoms, and then you see these cells. Yes, of course, you have to wonder if there is CIS, but CIS in a young woman is a very unlikely diagnosis. And so there, proactively look for this two-cell population, do a cell block, and do your SV40 immunostain. And that may be the way that you will catch these cases when you don't actually suspect them. Hope that answers your question. Any other questions there?
Yes,
in the...
yes, there
Mhm.
are a couple of questions how do we definitely differentiate between urothelial and SV cells? And there's a follow-up question that is it possible to do an immunostain to differentiate both, like gynecologic and urothelial origin, actually?
No, that is going to be based on clinical examination, cystoscopy, and colposcopy. If it's a gynae malignancy that is secondarily involving the bladder, especially if it is squamous in type, then it is going to need a gynae referral. If it's an adenocarcinoma that you are seeing in the urine, then of course, again, the same principles would apply. That this could be there could be a vesical fistula, there could be a vaginal vesical fistula through which this adenocarcinoma is coming in. In those cases, again, what you would have to rely on is, yes, you could do a Paxate immunostain. I guess if you're suspecting a gynae adenocarcinoma. You could do that on a cell block, but because it's such an unusual clinical situation, the imaging and the clinical examination and colposcopy will be more informative. So just the fact that you have alerted the urologist that they need to refer the patient onto the gynae team to be investigated further is a job well done, even if you not reached a conclusion, but you've said that there are possibilities here. This is suspicious, not so much of urothelial malignancy, but gynae or colorectal malignancy should be excluded. Then they will refer the patient to the appropriate tumor board, and the patient will be investigated appropriately further there. Any other questions?
Not for now, Dr. Chandra.
Okay, so I think I am going to have to call it a day because I'm getting tired. It's 6:30 in the evening, and I also have some of my reporting to do. So before we leave, our very last question, and let's see how confident you feel about reporting this case, having looked at a few cases of urinary tract cytology online, only a few seconds and just a few images shown to you. So this is the equivalent of a rapid on-site evaluation of a urine sample. So I won't give you any history here, but I want you to propose a diagnosis, whether it's negative, whether it's atypical, suspicious, malignant, low grade, other. What do you think at the end of this teaching session? would be your diagnosis for this last case? You can do it, I'm sure.
Yeah, I'm looking for options there in the chat box.
Are they
Please
being
go
shy?
ahead.
Okay, so the answer I'm looking for is high-grade urothelial carcinoma. I hope that besides a lot of these atypical urothelial cells, you've also seen sufficient number of suspicious urothelial cells with a high NC ratio, deep hyperchromasia, coarse chromatin clumping, and irregular nuclear membranes in sufficient numbers across this sample, across the many fields, to be able to make a confident diagnosis of high-grade urothelial carcinoma, or at least suspicious for high-grade, given that you haven't had a fair chance to really look at these images on your own and giving you enough time. But if I leave these images on the screen for you, I hope you will agree that you would be calling this at least suspicious, if not diagnostic, of high-grade urothelial carcinoma. Okay, thank you very much. I'm going to stop sharing my screen and I'm going to switch my video back on again. So I've realized, you don't mind me going on beyond an hour. I thought I was like way, way over time, and people will be thinking, when is he going to stop talking and let us get back to our real life day jobs? But
No, I
I'm
think
glad
this
that
was
people
great.
have persisted and stayed. Thank you.
No, our colleagues were all the time there. So there were close to 100 colleagues who joined on Facebook and YouTube, and they're all very appreciative of your
Oh,
talk and then sharing actually live cases. One question actually it was there
okay.
from before, which I can probably pass on to you right now. What are the practical challenges in implementing Paris system in low resource labs?
Yeah. So, I mean, low resourced labs should really not have any problems in implementing a terminology system, because urine cytology is a very common specimen type in a cytology laboratory. You're seeing large numbers of these cases. So in order to learn the system and to implement it should not be a problem. The sort of things that are difficult to implement in low resource settings are, ancillary um, tests. If we were talking about expensive immunostains or setting up fish or molecular testing, I would understand. But terminology doesn't cost anything to implement. So it is a question of, I would say, maybe having a presentation in the department by somebody who is familiar with the system, who has, read the book and is prepared to do it, or call in an expert to, give your talk. I have, given lectures on urine cytology or fluid cytology, maybe 100 times in the last 5 years to different audiences, online or in person, to other hospitals in London or across the country, and traveled internationally. I don't have to travel to, implement the Paris system. But, if you just wanted a talk like this, like the one today for your department, there will be people like myself who'll be prepared to help you implement it, to answer your specific questions, to do a sort of a tutorial, online tutorial like this, just showing you the commonest types of specimens that you might encounter in a busy cytology laboratory. We would be very, very happy to help you implement, urine cytology and the Paris system in your laboratory. So please reach out if you just want to implement it but need some advice. But it shouldn't matter because you're just employing knowledge which relies on morphology. Thank you. Great
Right, that's a
question.
great thought, Dr. Chandra. Yeah, for our colleagues, I think they can definitely refer to talks or, like reach out to Dr. Chandra directly if you
Yeah,
have any
yeah.
questions, not just the Paris system or any other implementation of any other systems, which, as you said, rely on morphology, not other ancillary tests. So there was a
Exactly.
question that
Yeah.
well, I left it. I think you might have already answered it. The question is related to differentiating between decoy cells and high-grade urothelial carcinoma. How do you do that?
Yeah, so with the decoy cells, as I said, they tend to be smaller than urothelial cells. They have granular cytoplasm because these are renal tubular epithelial cells, not urothelial cells. But also, you uh, you get a structureless chromatin. You get that deep hyperchromasia with a decoy cell. But you don't get the chromatin clumping and irregular nuclear membranes that are associated with high-grade urothelial carcinoma. And then you get this two cell population of the ones with the inclusion and the ones without the inclusion, where the inclusion has been sort of chewed up and spat out of the nucleus, the post-inclusion stage of the reactivation of the virus in the kidney. So you get the second population of very empty-looking nuclei. So those are the differences in decoy cells and high-grade urothelial carcinoma. But yes, I do recognize, and it is a recognized pitfall in urine cytology, the close mimicry of high-grade urothelial carcinoma by decoy cells from BK virus reactivation.
Thank you. There was another question on counting the number of cells. That do you count the discrete cells, or you also take into account the cells that are in the clusters when you decide the Excel number?
The number of malignant cells.
Yeah.
Yeah. You take into account both the dispersed cells and also the groups of cells. If you're on the verge of just calling it suspicious, but you've got 5 cells that are in a group and 5 dispersed cells, that may be enough to call it malignant if you feel reasonably confident. But yeah, it doesn't matter whether you're looking at groups of cells or dispersed cells. Either will do.
I think, Dr. Chandra, I am trying to see if there are some more questions. Most likely, these are the questions that are there, and just one last look if there is anything.
Sure.
I don't see anything online anymore. But thank you again, Dr. Chandra, for this excellent lecture. And our viewers are very appreciative of the talk, and they have posted a lot of comments of compliments in the chat box, and they have watched from different parts of the world, defying time zone. I saw that we had viewers who joined from countries far off as Mexico, Ethiopia, India, Bangladesh, Saudi Arabia, South Africa, and many joined from the United States as well. And thank you, Dr. Chandra, for educating us all on different topics, and we would love to have you again. And for the viewers, please, if you like these lectures, and please, you can find different lectures on our social media platforms, including the YouTube channel, Facebook page, on Instagram, and also on Twitter X. And as you saw that Dr. Chandra, you can reach out to him on Twitter X, and if you have any questions, you can ask him directly there, or you can reach out to us so we can pass on to Dr. Chandra. And this is the QR code you can scan so that you can get access to our YouTube channel and you can subscribe to it. And we will continue our lectures. Next week, we have a dermatopathology lecture, and our talk is on vesiculobullous disorders, and we will have Dr. Julia Lamon, who will be joining from Mayo Clinic, and that's on 3rd of December, same time, and hope to see you all at that time. And thank you again, Dr. Chandra, for this excellent talk. Hope to see you soon.
Thank you very much. It's been a great privilege and great honor. Thank you for inviting me. Thank you, Dr. Manan, and thank you all very much. Have a great rest of the day wherever you are.
I would like to appreciate and thank Dr. Asima Das for organizing and connecting with Dr. Chandra for this lecture and the previous lecture also. And thank you, Dr. Das. Thanks a lot. Bye-bye.
Bye-bye.